Welcome, ladies and gentlemen, to this symposium on improving patient access to rare disease therapies. Welcome to all of you in the room, and since we're being web-streamed live, welcome to all of you joining us from beyond. My name is Peter O'Donnell. I'm a journalist in Brussels, and I've been writing about health in Europe, among many other things, for quite a few years now. The challenging subtitle of this meeting is Value Determination, Appraisal, Pricing, and Reimbursement. And we shall, over the next 2 days, have time to look at all of these issues in detail and to hear views from you in the audience, as well as from our expert speakers and panelists. And this morning, those of you watching online can also fire your questions and comments into our reflections too, and we'll do everything we can to take those on board. The moment's particularly well chosen, the discussion that's swirling around all the questions of access and innovative treatment, who should get them, who should pay, how much, how to calculate what they're worth, if they're to be paid for, what will be the cost to the rest of the health system. And at the same time, the controversy swirling around the very concept of orphan drugs at the moment, with voices raised from rare disease patients demanding attention, while consumer associations, and no less a figure than the Dutch health minister, the current president of the European Union Health Council, is calling into question the EU's orphan drug system and suggesting that drug firms are manipulating the rules to make extra bucks. So it couldn't be a better time to bring real experts together for a dispassionate and perhaps at times passionate exploration of these delicate and difficult issues. And who better to set the scene than a patient advocate who has been at the head of this debate, and often ahead of it, for more than 20 years. Jan Le Cam, the Chief Executive Officer and one of the founders of EURORDIS, is well known for his work across Europe and the United States in cancer, HIV, AIDS, and rare diseases, and as many of you know, has a personal stake in the issue since one of his 3 daughters has cystic fibrosis. You've got full biographies, I think, in your pack, but Jan is well known at the EMA, in HTA, at the DIA, at EURORDIS, everywhere that orphan drugs and rare diseases are discussed. The discussion wouldn't be the same without his input. So please, Jan, would you give us your opening remarks? Ladies and gentlemen, Jan Le Cam.
Thank you. Good morning, everyone. It's impressive to see you so numerous. We were expecting 150, 180 participants. You are 300. So that tells about the traction of the topic. And the purpose of this symposium is one and simple, but ambitious. It's improving access to rare disease therapies. I think we all praise the EU regulation for its success, one of the most successful of the European Union. And we all see the huge scientific opportunities to develop new rare disease therapies in coming years. In 15 years, there is 116 orphan products which have been approved with a marketing authorization in EU for 138 different therapeutic indications, among which 31 of these products have lost their orphan status after the 10 or 12 years of market exclusivity, which means that there is 85 still with orphan drug status. It doesn't stay forever. Our Horizons shows that there is over 1,600 orphan drugs designated, some development obviously abandoned, but most of them still ongoing. And we are able, based on the experience of the last 25 years, to predict the number of products from designation to marketing authorizations. We can add another 80 medicines which have been approved without orphan status, either because the companies don't follow that pathway or because they are not able to show significant benefit. In last 2 years, each year, there was between 20 to 30 new rare disease therapies approved in EU and US combined, either with orphan status or without orphan status. So this is a steady trend. Within the International Consortium of Research on Rare Diseases, in 2010, we set an ambitious objective to develop 200 new therapies by 2020, which at that time sounds really ambitious because the trend was 100. And the news is that we will reach that goal by the end of 2016, 4 years in advance. So there is an acceleration there. And this gives, again, an idea of the opportunities ahead of us. By 2020, in EURORDIS, we estimate that we will have between 30 to 50 new therapies approved every year. And that's a good problem to have. Hopefully among them there will be some real breakthrough, something that is curative, something that really changes the lives of patients and the health outcomes. But for most of them, it will be limited or uncertain value. Even if it's good enough for risk-benefit assessment, for orphan approval or maintenance of orphan status, it may not be clear enough after that for HD and for payers. And there is one of the first misconceptions I'd like to highlight is that for each rare disease, it seems that the community, I'm not saying only the payers, but even the community, even us as patients, we think that we're waiting for the one magic treatment that will change our life or that will be curative. But that's exception. We are a chronic disease. And look at the other chronic diseases. It's always a combination at the end. It's always incremental progresses. So there is no magic here. But what it means is that these different treatments, with their complexity, with their interactions, but also with the adding cost, will increase the level of challenges ahead of us. These huge opportunities from translational research are a good problem to have, really, and we should not be afraid by this evolution. But what we need is to adapt. The current model doesn't work anymore. We cannot go on like that. We have to change. We need to make it evolve. And the main issue we are facing is access. We estimate that 1/3 of all rare disease patients don't have access to the approved medicines for their condition. They are waiting for years. Access is highly unequal to rare disease therapies in Europe. Patients in the 6 main EU markets get the new treatment pretty quickly. That's doable, even for small companies, even when it is a very small population across Europe. But then you have patients in 22 other countries who are waiting. And they wait between 1 to 8 years before they get it. Sometimes parallel imports helps, or there is other ways like the access program, market and access program, things like that. But it takes years. On this poster of the Ramussen family, they were on a poster of the Rare Disease Day some years ago. It has been a maze for them to have access, reimbursement, even though everybody was trying its best. And that is an EU member state. So wouldn't you agree that if an innovative treatment is approved but doesn't reach a patient, it falls on its primary objective? So we're talking here about our lives and the lives of our children and beloved ones. And here on this photo behind me, you see Maria Joldik with her son Philip. And Maria is with us streaming online this morning from Belgrade. Philip is 9 years old. They live in Serbia, in Belgrade. Philip is affected by an MPS disease. They have access to the best hospital locally, and their doctors collaborate with doctors in Germany. Maria is the president of the Serbian Alliance for Rare Diseases, so she's a resilient person. She developed a patient group, she developed the National Alliance. And a treatment was approved in 2007 for that disease, which transforms it into a chronic disease, and you can live almost a normal life with the treatment. But Philip had access to that treatment 7 years after the approval. Treatments work for him. He's doing well when he has the treatment, but that was only for 1 year. And then at the beginning of this year, for bureaucratic reasons, so nothing to do with the company, nothing to do with value and reimbursement here, bureaucratic reasons, he didn't have treatment for 5 weeks. and he was at the hospital. Philip died last week. Treatment arrived too late. If he had it when he was 2 years, he will still be here on this earth to continue the journey with his mother and his family. Access was too unstable. So this is what patient access means to a patient and a family. This is what value of medicine means when value is uncertain and that you have to wait for years before the decision makers can make a decision locally, because they have to watch their budget, which is limited, as you can guess, in a country like Serbia, which is challenged by economic crisis. This is what sustainability means when value for money is a too high burden for this healthcare budget, in their opinion. And this is what it means when we say that patients exist, medicines exist, but the process is wrong to bring the medicine to the patients. We are dedicating this symposium on improving patient access to medicines to Philip and his family, and I will ask you to observe 1 minute of silence. Recently, some important medicines are not being made available because they are perceived as being too high priced in comparison to their determined value. And in recent years, we are observing growing divergences of decisions. So there is the marketing authorization, then the drug is approved with high value in one country and paid at a certain price when the other country says, no, sorry, I don't see the value, I'm not reimbursing. And we see that growing and diverging across Europe. How can we understand that as patients? And how society can understand why they would pay in the UK, not in Germany, why they would pay in France, but not in Spain. For us, there are two drivers for change, the scientific driver, the economic driver. The scientific development for rare disease therapy is a continuum of evidence generation. And that's the other misconception we would like to address, is that there is this dream that clinical trials does it all. It doesn't in our case. That's an arbitrary, homogeneous selection of patients. The expression of our diseases is highly heterogeneous. We need the real-world evidence after market authorization. We need continuum of evidence generation. We need continuum collection of evidence and regular reassessment. Economic driver. We need affordable medicines. There was a time to make this area emerge. There is now a time when we're going to have 30, 50, maybe more drugs per year. We want to see your companies coming with larger portfolio of products, and instead of living of 5 or 10 products, we would be happy to see you with much more products, maybe with lower margin, but with a much stronger portfolio. This is what we need to come to. You're looking for the reward for innovation. You need to reward your investors, and this comes into value. Value-based pricing is not only the value of the medicines, it's also what you spend, what you need to reward, what you need to invest next. And this is needed because we don't want this money to go into, it might go to, but into aeronautics or web industry. We want it to come into that industry. So we need the right level of reward. But it needs to be fair prices and fair burden for society. Sorry, I'm skipping some of the presentation. I'd like to go directly to the fragmentation, to say that this fragmented doesn't work. Why? Because a series of rational decisions in member states by HTA and payers, they try to do right, that's fine, and they have their constraint to manage. But this series of decisions doesn't work, as we saw. It takes years to bring the drug, but also at the end, that doesn't make a rational decision across Europe. So that has to change. This fragmentation is simply killing people. And we suggest that rather than continuing to contemplate the problem, we need to fix it. It's years of discussion, it's years of working group, it's years of position papers between multi-stakeholders. Now, can we get our acts together and be a bit more daring? And we need everybody to dare. We need the payers to dare, we need HTA to dare, we need the companies to be willing to dare, and you are willing to dare. The problem is that collectively it's difficult to dare. within umbrella industry groups. But this is what we need to come to. 9 months ago, and I will conclude with that, EURORDIS and European Patient Forum launched a call to national competent authorities on pricing and reimbursement in order to engage collaboration between volunteering EU member states on improving access to patient care. And basically we're calling for 2 things. Early dialogue between payers and companies, exactly as you have at EMA or HTA now, that kind of early dialogue in order to do horizon scanning, in order to present your product, in order to integrate some of the concerns ahead for the payers, and to prepare the market access scheme for that product, particularly, even more so, for the most innovative products. Second is to call for a table of negotiation at the European level. And we know we're calling for a big change when we say that. We're not asking to put the money into a European pot. That we don't want. The money stays in the member states. But that doesn't prevent them to come together to assessment and to decisions together, and even to contract to purchase or market entry agreement, call it whatever you want. There is several options here which are being discussed. But if we are able to do that, then we are able to link development and access, generation of evidence and price and value in the middle. That's a dynamic. It will provide a structured market access rather than this fragmented access. With a European scheme, it will be a more seamless process between EMA and HTA, which we increasingly have, thanks to scientific advice and HTA participating, early scientific dialogue at HTA with EMA participating. Now we need the payers into that, and we need to come to discussion at European level. Simply because of the rarity, it doesn't make sense to discuss locally. We're not talking about drugs in general. We only care for the moment for the one on rare diseases. And that's the only way to reduce the high uncertainties of most of these drugs at the time of marketing authorization. We cannot together as a community push for earlier access to medicines for patients and at the same time continue with this fragmented approach. If we go early to market, it's normal that we have good enough for risk benefit but not good enough for value assessment. So either we want to do value assessment at that moment and then we need to collaborate, or we give it more time to generate evidence for a few years, and then we do value assessment later. But we need to find other ways to do it. And what we would like at the end is to make Europe the best place in the world where rare disease therapies should be developed. So we need this new economic model. We need a new deal between industry and society, and this is what this symposium is all about. Thank you.
Thank you very much, Jan. And I would, if you'll permit me, just ask you one question which may seem almost too evident. You've made this deeply personal statement of the situation based on real life experience, real problems of real patients. You've been involved in this for 25 years. How come the strength of the arguments that you have are still not moving forward to find the sort of solutions that are necessary?
Only a guess that I can give to that. What I observe today is that from the patient advocate's perspective, it's pretty clear what we want. And we're saying it. And this is what the important fact of putting this paper out last year, the call to national competent authorities. It's clear that from the payers' side, from what I understand, we understand, they are willing to do so, but it's difficult to overcome, to explain internally, to overcome some of the resistance internally. There is also the barriers of languages. There is also the barrier of how technically we're going to make it. There is also the uncertainty of, is that welcome? But what I can see is that because of the budget pressure, because of the growing misunderstanding and mistrust, sorry to say, between industry or part of that industry and payers or part of the payers, suddenly policymakers might take tough decisions just to show they make decisions to fix the problem. That may not be what we want exactly. So now for me, what is waiting, what is important is to have industry, either some companies or industry as a group, to come up and say, okay, we got it. It's going to come. It's coming between Netherlands and Belgium. It's coming between Bulgaria, Romania, between Serbia, Croatia. So we're going to propose you how we see that working. And these are proposals that could be workable for us, whether it's a new deal. This is what I would expect to make things move.
Thank you very much for that. We'll move on, and let me introduce to you Kees Smit, who's going to talk to us about living with hemophilia. Kees is a policy advisor. Many of you know him very well for EGAN and VSOP. He's another veteran of the rare disease community, if I may use such a term, and again, with a very strong personal stake. He's been a member of Leiden University Medical Centre's research project, Haemophilia in the Netherlands, since 1978, and has also worked extensively on patient participation and mental health. He's an author, an honorary doctor of the University of Amsterdam, and he's here to talk to us this morning. Please, Kees, thank you very much.
Thank you, Mr. Chairman, for this kind introduction. Also, thanks to EURORDIS for inviting me. Ladies and gentlemen, dear friends, yesterday evening, Jan Le Com ended with a tribute to the families of persons with rare diseases, and I would also like to start with that. I would like to pay tribute to Robert and Suzanne Massey, an American couple who wrote a book, Journey, that was published in 1975. This is maybe the quintessence of the book, and this book can also be seen as one of the drivers to get attention for the problems of families with rare diseases, and therefore also contributed to the US Orphan Drug Act, signed by Ronald Reagan in 1983. It were the same problems the Masseys experienced with their son with hemophilia that my parents had gone through after I was born in 1951 with severe hemophilia. Hemophilia, a genetic disease characterized by a missing blood clotting factor for which there were no treatment options in the 50s and 60s of the last century. Hemophilia causes primarily internal bleeds in joints, knees, elbows, and ankles, leading to immobility and long periods of rest and stay in hospitals. My parents had a bakery shop in a small village in the Netherlands, where I grew up together with my sister, who is a carrier of hemophilia. And the impact of the disease was that my parents had to stop with the bakery, switch to another job, and move to a place more close to the hospital because I stayed long periods in the hospital. Although I was a spontaneous case of hemophilia, it was rather quickly diagnosed by the first pediatrician my parents consulted. This pediatrician had been a student of the well-known Professor Cornelia de Lange, who saw a lot of hemophiliacs in her children's hospital ward in Amsterdam. And so, after the diagnosis, my parents were told that my life expectancy would be limited, and most probably I wouldn't get older than 20, 30 years. Here in the story, I also have to make a remark about my short stature. In my case, this had been caused by a drug, DAS, diethylstilbestrol, that was used in the 50s and 60s in the first place to prevent pregnancy problems and miscarriage. But it was also seen as a miracle drug in a number of other diseases, and one of them has been the use in hemophilia. At the time, there was absolutely no cure for that. In my younger years, I went through a number of life-threatening bleeding episodes, so my parents agreed with the treatment with this experimental drug. The idea behind it was that through the medication, my growth would be stopped, and possibly that could limit also the number of bleeds in my joints and muscles. That theory proved to be wrong. By the time I became 16, treatment options for hemophilia became a reality. I got my first treatment with a plasma product which contained a high concentration of the missing clotting factor. It immediately worked, and the regular treatment with this new product changed my life. I could attend school and university on a regular basis, and after a few years I could give myself the intravenous injections at home. I rarely had to visit a hospital for hemophilia anymore, and my life expectancy became normal. And so I could celebrate my 65th birthday on the first day of January of this year. More than 25 years ago, we evaluated the outcome of modern hemophilia treatment in terms of longer life expectancy. Relevant patient outcome measures were reported in terms of absence from school and work, and this has decreased substantially over the years, and participation in the labor force increased. Visits to the hospital were also substantially lower. And please note that at the end of the abstract, in 1989, we wrote that the high costs of modern substitution treatment are fully justified. Within 50 years, 2 generations, the picture of hemophilia totally changed from a survival hospital in 1965 to a survival camp in nature in 2015. A drawback in the hemophilia community occurred in the 80s with transmission of HIV/AIDS and hepatitis C through the blood plasma products. The best of times transformed in the worst of times. Many of us died. Some of us survived till the time that an effective antiviral therapy for HIV was found. And by now also a cure for hepatitis C is within reach. I was lucky that my hepatitis C could be treated successfully a couple of years ago already, and also my HIV so far. The history of hemophilia illustrates that the hemophilia community is highly diversified. From young people who can lead an almost normal life, to the older aging group who can also live an almost normal life, but with a lot of mobility problems and comorbidity issues, and a complex number of contacts with healthcare professionals. The viral complications I mentioned made it necessary that safer products came on the market, be it safer plasma products or through new product concepts like recombinant DNA clotting products. Safer also meant more expensive, and so gradually over the years, hemophilia became a treatable disease, but also one of the very first expensive rare diseases, with an average cost of around 65,000 till 150,000 euro a patient per year in Europe for severe hemophilia. A concern for all of us in the hemophilia community. Nowadays, I read in relevant HTA studies sentences like, prospective, well-conducted studies on economic issues in hemophilia care are scarce, or randomized clinical trials of hemophilia patients is difficult, not only because of low patient numbers. It's strange to realize for hemophiliacs and their families that what started as an enormous breakthrough in the treatment of a rare disease 50 years ago is nowadays taken over as a matter of concern of HTA scientists and economists. However, it's highly unethical to withhold treatment to a newborn hemophiliac because first its efficacy should be proved in a randomized clinical trial, when we already know from the pre-HTA era that the proof of the pudding was an NS1 case study. Something other scientists described as the parachute effect. Never organize a randomized clinical trial to prove the efficacy of parachutes because you can predict the outcome in advance. Today, aging is a trendy topic in my personal life as well as in hemophilia care. Aging is a new proof of the pudding that the therapy is working, but its eating is hampered by cost concerns. What we really need for the future is not only good quality care for the elderly, but also some drastic technology breakthroughs that cure rare diseases like hemophilia, but at least makes treatment substantially cheaper. What we need now is a new generation of HTA scientists, those who bother about these cost considerations in a much more constructive way by looking also to new technologies, for instance gene therapy, and scenarios that can provide a solid and sustainable basis to these new technologies. In other words, from the classical approach to HTA to early medical technology assessment, or in my own words, constructive technology assessment. A valuable contribution to the price concerns could be delivered by involving physicians and patients in the process of price negotiations. The European Hemophilia Consortium recently published data which clearly showed that such a process can lead to lower prices, especially when also patients are involved in the negotiation process. Finally, I would like to quote Robert Massey, the main character of the book Journey from 1977. In 2012, he himself published his memoirs, A Song in the Night, a memoir of resilience. Also, Robert Massey became HIV and hepatitis C infected, and therefore he needed a liver transplantation. This liver transplantation led to the disappearance of his hemophilia, something he never expected. And what remains today is the wish of the total hemophilia community to find a more final solution for this rare disease. Thank you very much for your attention.
Thank you very much, Kees. Please come and join us over here. We will have time for questions. We have a panel session after our speakers have spoken. So I'm going to leave it to you and the people watching online to fire your questions in when we're having the panel session. I'm now going to ask you to welcome Mr. Joe de Kock. Joe de Kock is the Chief Executive Officer of INAMIR, as if the National Institute of Health and Disability Insurance. He's also a Master of Law, and I discovered to my delight this morning a Master of Criminality, although I hope he's not going to have to deal with that too much this morning. Criminology, I beg your pardon, I'm so sorry. It's not quite the same thing, is it? That's the sort of mistake that gets moderators into trouble. My apologies in advance. He's also been a long-time advisor to the Belgian Prime Ministers, and he now appears in the middle of, or very often as a wise man behind, many of the debates on the tough topics that we're discussing this morning, and particularly in that broader discussion of areas of reimbursement and access. So please, ladies and gentlemen, welcome Mr. Joe de Kock.
Thank you, Chair, for these kind words. Ladies and gentlemen, first of all, I want to congratulate EURORDIS and its partners for organizing this multi-stakeholder symposium on improving patient access to rare disease therapies. This initiative is fully in line with the call EURORDIS launched last year in May, together with the European Patient Forum, to the national competent authorities for pricing and reimbursement, stressing the need for establishing new mechanisms that would improve access to pharmaceutical products for patients in Europe while addressing the upcoming challenges in terms of sustainability of our healthcare systems. Indeed, health systems have to pursue a number of important objectives: to increase quality, to improve equal and affordable access to valuable innovations for those patients who need them, to guarantee equity and solidarity, and to control costs in order to maintain the sustainability of the health systems. This conference responds to what I would call an unmet societal need to bring together all the stakeholders involved in order to discuss these important issues. Since 2010, a number of initiatives were taken in order to foster a debate on a European level on the topic of solidarity and innovation. Not without any pride, I want to refer to a report the Belgian presidency launched in the second half of 2010, in which was made a call to make valuable, innovative medicines accessible in the European Union. This report formulated a number of recommendations for a coordinated action to stimulate, measure, and valorize pharmaceutical innovation for the benefit of the patients. It was a plea to build bridges between the different stages of development of medicines, research, market authorization, and pricing and reimbursement issues, to fight against the fragmentation. And this based on a life cycle approach. But the report underlined also the necessity to safeguard an equitable access for truly valuable medicines for all European citizens, underlining also the variations in uptake of these innovative medicines and underlining also the huge differences which are greater than the GDP measurement. Probably it is not unnecessary to highlight the different dimensions of access. The question of timely access is mainly an issue for public health. The problem of equal access is related to social policy, and the issue of affordable access is clearly linked with the challenge of health system sustainability. As a result of these discussions, the Council of Ministers formulated a number of conclusions in 2010 on this theme. Some of them may be recalled. For instance, the need, and it was a clear invitation to the European Commission to encourage cooperation in the field of health technology assessment. Nobody can neglect that in 5 years' time, an enormous progress was made in this field. The ongoing and new Joint Action 3 proves clearly the added value to invest in this domain. But another conclusion concerned the call to member states to participate in pilot projects on coordinated access to orphan drugs. The objective of this project was to examine and to test mechanisms for coordination and cooperation between a number of states, covering the full part for one or more orphan drugs, pricing and reimbursement issues included. The project is better known as the MOCA initiative, and you have documentation in your map. Belgium chaired the working party. In the terms of reference of this project, it was clearly stressed that decisions on pricing and reimbursement are the exclusive competence of member states. But nevertheless, these member states foster the same undisputed principles of equity and solidarity, face common challenges when providing indispensable medicines for the patients and suffer similar burdens when organizing this access. All of these issues become even more explicit when a limited number of patients are concerned and possible answers to respond are scarce and expensive. The aim of the project was to discover way forwards in a win-win approach. The initiative, which is still continuing, tackled three elements: assessment and evaluation methods, the development of a transparent value framework aimed to help member states to introduce coordinated access pathways by providing a consistent terminology and methodology. And thirdly, last but not least, proposals to integrate the approach in an integrated and comprehensive structure at national level linked to the rare disease plans, which will ask to be implemented in every member state. Looking back to the outcome of this initiative, I would like to stress the three following elements. First, an important number of member states are involved in this project, and this on a voluntary basis. 40 member states are working together. The meetings can be considered as an early dialogue opportunity between competent authorities and manufacturers. The early dialogue is focusing on the targeted disease, the products and its development, the approach, and identified challenges to access to markets with a view to ultimately making the product available to patients across Europe. It is important to underline that it is a unique platform, highly appreciated, where the issues around reimbursement and new financing schemes are discussed with a great variety of jurisdictions and societal perspectives. It's an inspiring experience, resulting in a cross-pollination and exchange of expertise in open dialogues addressing access to the market issues in a broader sense. Secondly, there's clearly a need for a more structured governance approach and a long-term agenda. I will come back on that. And thirdly, the initiative shows clearly the need of capacity building, the link with centers of expertise mentioned in the cross-border directive, and the necessity to invest in appropriate registries. In 2014, in the slipstream of the Hep C discussions, the European Council of Ministers formulated a set of clear recommendations on innovation for the benefit of the patient. And they invited, again, member states to explore opportunity for cooperation on exchange of information between competent bodies in relation to a life cycle approach for innovative medical products. By the way, they charged the Working Party on Public Health at senior level to continue their work. And concerning this point, I have to mention the fact that the Luxembourg presidency, together with the Netherlands, Malta, Slovakia, but also Belgium again, presented in July last year a roadmap for those discussions, defining 10 clear action points. Develop common perspectives on the challenges associated with access to innovative medicines, including elements such as cooperation on assessing the economic value of personalized medicine in order to be prepared of what's coming on. Anticipating future trends and developments by means of a joint horizon scanning exercise. Reflection of the effective use and impact of the existing regulatory tools of accelerated assessment, conditional marketing, authorization in exceptional circumstances. But also an analysis on the financial impact on national budget of specific financial incentives which can be given. Information exchange on drug use, market structure, and other relevant information that support member states in pricing and reimbursement decisions. But also, and it's important, the development of joint approaches on pricing and access schemes for the coalition of the willing, including payment schemes and joint and voluntary negotiations. A lot of other points, I will not mention them all, but finally it's concerning the proposal of further integration and coordination functioning in and within the different fora existing on the European level, coming up with a global governance on these issues. Of course, we should not only plan, but also act. And therefore, last year, the Netherlands, Luxembourg, and Belgium co-signed an intention to collaborate on pharmaceutical product policies, provoking some nervosity on the side of the pharmaceutical society. For Belgium, it was put forward as a clear priority, mentioned straight away in a governmental agreement. And for us, it's a little bit paradoxical to see that while many manufacturers have launched calls for cooperation and dialogues with payers, they take some fear and think that the table we're offering is a booby trap. End of March, at the Multi-stakeholder Forum organized by the European Commission and the Dutch presidency, we will be able to make a first state of art of our discussions. What I can say today is that the objective is to come to a fruitful collaboration between the involved authorities, which will make it not only possible to control the price of medical products, but also to increase the efficiency of assessments through exchange of expertise and recognition of each other's assessments. In that sense, it's an exercise of knowledge building. And 4 elements are concerned. First, the exchange of information and knowledge about drug consumption, best management practices, post-marketing evidence, and specific policy questions, example given the high-priced medicine. And the Belgian Knowledge Center and the Dutch Zorg Institute are preparing a study in this regard, which will be published this year, exploring ways to break existing deadlocks. A joint development of an horizon scanning tool which can foster dialogues and allow to prepare coordinated negotiations. It's not sufficient to say we need an horizon scanning. The question is to make it and to act it. Thirdly, the joint health technology assessment, together with, of course, the joint actions which are going on, but also by testing models for implementation, by mutual recognitions of experts, mutual recognitions of our reports, by joint writing, by joint editing, and by sharing operational expertise. Third element of this agreement is a negotiation of managed entry agreements compatible with national legislation. In this regard, some pilots are being prepared, not in order to come to joint procurements, but in order to streamline as much as possible our mutual approaches. It is our commitment to play together an active role in all these European fora and examine carefully the eventual outreaching of our initiative, partially or globally. For the moment, we are putting together different building blocks. We do this in a serene climate in order to develop an evidence-based and experience-based mechanism. When we evaluate the last 5 years, nobody can deny that a lot of work was done and progress was realized. Belgium has tried to play an active role in that and will continue to do so. But it's not sufficient. Quoting Bill Gates, who once said that people are overestimating what can be done in 1 year, but underestimating what can be realized in 10 years, I'm very confident that within 5 years, all those initiatives will lead to progress for a lot of patients in Europe. I thank you for your attention.
Thank you very much, Joe. If I can invite you to join us here. Your remarks are customarily sage and provocative in many respects, and I'm sure many people will have questions. I'm bursting with them, but I shall contain myself for the moment. And it's my pleasure now to introduce Philip de Backer, MEP, Liberal MEP in the European Parliament, who's also highly prominent in discussions of health matters in many respects here in Europe, who also has, of course, a background in venture capital, a PhD in biotechnology, and is probably sick to death of hearing me introduce him, because I have the great pleasure of seeing him with extraordinary frequency over recent days, but he may not be quite so pleased. But anyway, Philip, great welcome. Please welcome Philip de Backer.
I'm always happy to see you, Peter, because it means something exciting is going on. And so thank you, ladies and gentlemen, for the invitation here today to speak before you. I think it is almost exactly 1 year ago when I gave my first speech before EURORDIS a little bit closer to the European Parliament then, where indeed many of the principles that you all just laid out, I also put them forward in my speech. And it's also the title of my speech today, how the European approach can really help to improve patient access. A lot has been done. We have an EU regulation on orphan disease. We have some cooperation and some studies and work by the European Commission. I think the Commissioner will also later on speak about this, on bringing experts together, building expert networks, making sure that centers of expertise coordinate and cooperate better. We're working also on making progress on early diagnosis. All these things are ongoing and I think are moving in the right direction. But I think that the title of my speech also indicates that there is still a lot of work to be done. Because as many of the previous speakers have described this, when we start thinking about improving patient access, if we have a look on how the system works today, we have still this fragmented system. 28 different member states with different sets of rules, different access, different quality, different regulatory regimes, which makes it much more difficult for patients to have fundamentally access to new and innovative drugs, although they are available and approved on the market. And of course, if you look at the situation, and I think Jan described this very clearly with some personal examples also, the ones who are suffering today are the patients themselves, of course. Still, the healthcare outcome depends on what country they are born. This is not the promise that the European Union has had for them. And so I think that it is my job as policymakers and our collective responsibility as policymakers to make sure that indeed the discussions are finalized and actions are being taken. And as you know, I've been over the last couple of months and years a very active and very strong supporter of increased cooperation at the European level. And some of you may also know that I've been presenting concrete proposals, also in discussions with the European Commission and Member States, to make sure that we can address and solve some of these issues. It is the same proposal that I present still here today, and Peter knows this because indeed we encounter each other on many different occasions, and I think that I haven't let one occasion escape without talking about my proposal of the Rare Disease Fund and the discussion that is also ongoing with the European Commission and Member States. The approach is simple. We have to start cooperating and developing schemes at the European level. We have to make sure that we set up true HTA for new innovative drugs at the European level. Looking at real-world data, doing early dialogues between stakeholders, all stakeholders. And I think that today companies still spend a lot of time figuring out how these 28 different regimes and assessments are working. They're asked for new data, different data. And so I think if you can streamline this part of the process, it would be a huge benefit. The next step, of course, also makes sense. Once you have agreement about data and how you should evaluate those, it is also easier to have a discussion, a frank discussion, an open discussion on pricing and reimbursement. And also there, I think we need to be more innovative. You see today a lot of member states experimenting with new ways of reimbursing, also making it a lighter cost for the healthcare system as such, but at the same time providing the access, the quick access that patients are demanding. So also innovation here in this area is still key. And of course, ultimately, if we develop a European scheme, it is also clear that we have to make sure that all patients across the European Union have the same access to what is then presented. And so we need also the buy-in of national health services, of course, to make sure that they cooperate, that they exchange information, that their patients get also the same standard of care no matter where they live or where they are born. And so taking these decisions at the European level, or at least trying to coordinate these decisions at the European level, I think would help a lot and would bring us really, really forward. And I think indeed, as the question of Peter already indicates, there is a lot of mistrust today between member states. There is a lot of discussion ongoing about how the European Union should look like in the future. But I think even all these heads of states of the 28 member states can agree and can see not only the emotional but also the very practical and very personal statements that are made by some of the patient organizations. And I think nobody can remain indifferent. And if the solution is there to grasp, it is right in front of us, then they should also be pushed to act. Because the proposal that I've put on the table has several advantages. We look at 500 million European citizens all at once. The benefits for the pharmaceutical industry is very clear. Their red tape, their bureaucracy, of which they often complain, is cut. The benefits for the patients are also very clear. They will have earlier access at a more reasonable price than today. And of course, also for the healthcare systems, the benefit is clear that they can negotiate and reimburse at different levels, at different price levels. And so I think with this proposal, all the stakeholders are around the table. And as Jo described, the discussions are ongoing. I hear a lot of technical debates, a lot of difficult debates, a lot of things that we cannot do. Well, basically and frankly, I'm no longer interested in the 10 reasons why we cannot do a certain thing. I'm interested in finding a solution and find the one reason why we should do it. And the one reason is very clear. It's patients. It's patient suffering. Patients who are today unnecessarily suffering because there are cures, there are possibilities of better healthcare for them already available. And so I've been pushing these ideas everywhere where I go. I think Peter is also bored of of listening to me speaking about this. But in the end, I think that we see already some progress. You described also the proposal and the actions being taken by Belgium, the Netherlands and Luxembourg with the joint purchasing scheme and the discussions that are ongoing there. Indeed, it's ruffled some feathers. It made some people a little bit anxious. But I think it is really, really the right way to go. And I hope that we can also expand the scheme very soon. Because in the end, we have a choice. We have a choice between being disappointed in the lack of political will in many member states to move forward on the idea that is outlined here, or we choose to be optimistic. We give all our support to the member states that do choose a way forward, and I suggest that we do the latter. I am an optimist. Even the European Union started only with 6 member states. Even Schengen originally was only 5 member states. And although there's a lot of pressure on those institutions and those treaties right now, I think in the end they will survive and come out much stronger. So my message today is that change can happen, change will happen. It will be a hell of a fight for all of us who are involved in this, but I'm very, very proud that I will walk this path with you, and you can count on my support. Thank you very much.
Thank you very much, Philippe. And now we'll move on to our panel session, and it's my pleasure also to ask Andrea Chiesi to join us up here on stage. Andrea is the portfolio R&D, head of R&D portfolio management at Chiesi. Chiesi, as I think all of you know, is a family company with a particular interest in development of rare diseases. And I'm very glad to be able to welcome him to the stage to join us here as well. Please come and sit down here with us, Andrea. Thank you very much indeed. We have a policy of equity of access to applause in this organization. So thank you very much. Andrea, let me ask you straight away, since you've been kind enough to join us here. Yes, pick up a microphone. You've heard some discussion, a lot of different angles, and several times when industry has come up for comment in the remarks we've heard this morning, it's been associated with observations about impatience, observations about misunderstanding, even of mistrust. Now, I'm sure none of these observations relate to Chiesi, but since you're the only person here from the pharmaceutical industry, and it's no accident, can you give us a view, perhaps just from the industry position, of how you perceive these discussions and these senses of unease or disquiet or discomfort about misunderstanding, mistrust, and impatience?
Well, thanks for having me here today in the bad position, which I'm glad to represent. I'm glad to represent because I do not feel bad, but I do feel optimistic, as has already been said. A lot of things have been done in the recent past that I think go exactly in the right way, that several times has already been touched this morning here today. And the conditional approval pathways that the European agency has put together and the early access schemes that are being carved out in the legislation are 2 very good examples of we are doing steps in the right directions. And also, what a lot of people might not know is that there's a lot of dialogues, a lot of discussions going on involving public entities and the industry. There's a lot of places where we can have talks, like I hope is this one this morning, representing the different points of view in a frank and fair way, if that is possible at all. Of course, I have a few thoughts also on what is ahead of us. There's several things that I think should be done, and I would limit my, my point of view to two ideas. One is sustainability. Sustainability has to be in place for everyone in the chain. Sustainability has to be for the health systems in the different member states. They have different purchasing power. Price then is something local. But if we discuss in 8 years, I was astonished to hear that it took 8 years to get price from the first to the last, of not all 28, by the way, because it was a few years ago. Countries in Europe, it's crazy. I mean, that's absolutely something we should work upon. But we don't forget that the purchasing power is different. So what is okay to be bought in Germany is not okay in Bulgaria. And so we have to take that into account. So I think that sustainability is very important. And the more rules we put together, the better on the one hand. On the other side, it puts a lot of burden, a lot of costs on the industry. Because every rule we have to comply with bears a cost. And I will only make one example with the infancy milks. A few years ago...
I'll only let you make one example at the moment, but please go on.
We accepted to use Chinese milks, and then children went to hospital because they were cheaper. So I know rules have to be there, but they have to be clever rules. So sustainability has to be thought about for all the entities involved. Second, we are here for patients. So patient centricity, put the patients at the center, is also paramount. We have to ask them what they need, what they want, what they value. Sometimes the endpoints that we are forced by norms and laws to follow during the development of our drugs are not what the patients want, actually. And so, again, it's an integrative process that has to take place, involving and including, and inclusion is the key word here.
I'm going to interrupt you there, if I may. I will come back, of course, to many of these things. But that's an interesting point you raise about a certain discordance or, should we say, inconsistency between what patients want and what, in a way, the regulation allows and so on. It's another example, perhaps, of misunderstanding and mistrust. Joe, can I bring this question round to you as to how you perceive, from your position, the risks of misunderstanding and mistrust? You spoke about, certainly, the need for greater degree of mutual recognition of experts, for instance, in HTA and other aspects like that. Are there other areas, though, that you feel can help to move from words to deeds in terms of resolving any misunderstanding and mistrust that you perceive in the system that you're part of?
Okay, I think, of course, there are the technical questions we mentioned. I think there's not a hot potato in the room, the health technology assessment. The question is, how can we realize in a short time common methodologies which can be practical and which can be dealt with by different member states. I think sharing expertise, that's not the biggest issue. The biggest issue of mistrust is a question, of course, of pricing and fair pricing and the strategy thereon. And I think that's clearly something which should be put forward on a more clearer way to deal with. And of course, we have barriers on the European level. When you have one price in one country and a lower price in another country, you are confronted with parallel trade, you are confronted with reference pricing systems, and so on. And therefore, it's my conviction, my strong conviction, that we should create fora in which we can discuss about more innovative financing and reimbursement mechanisms in which we create win-win situations, both for patients, as for industry, as for the payers themselves. There are some ideas on the table. It's a question of lump sum financing, a question of differential pricing approaches, and other annuity approaches. There are some schemes which are on the table, and I think following up what Jan said, okay, can we create a table in which there is sufficient trust? That's what we try to do with Belgium, Netherlands, and Luxembourg. And I know there's a lot of interest by other member states, but also by industry, to say, okay, what's going on? And I think we should have the fairness to discuss about these things. And of course, wording is important. We are not dealing in Belgium and Luxembourg and the Netherlands with joint procurement. We are preparing our discussions on a common way, putting the same questions on the table, but we are not going to joint procurement. We are not installing procedures which are impose more time and which are prolonging the time schemes for coming to the market. That's not the case. And I think clarifying what the common understanding about it, about these elements, can be very in favor of bringing more innovative medicines to the patients.
Okay, thank you for that. Kees, can I turn to you for a moment and first of all wish you a happy birthday, although it's a little bit late, but never too late for a birthday wish, particularly for you. Joe just said that HTA isn't really a hot potato in the room because everyone accepts, I think, that HTA is a very good idea and there's a lot of work going on trying to make it work. From the patient's perspective, do you feel that the balance between the different interests, which are obviously the companies making the drugs, the payers who are going to have to decide upon whether to pay for it or not, and the patients who are the ultimate beneficiaries, hopefully, of this, do you feel that those conflicting interests are fully respected in the way that HTA is currently organized in Europe?
That question could be expected, and I wrote it down already. I think the large difference for patients is that when you are talking with your physician, you have a direct human dialogue about your medical problems and possible solutions. And what struck me in the contact with HTA people since about 10 years, HTA field for about 20, 30 years, when it was much more in the when it was much more in the atmosphere of working together to try to get solutions, but the more form HTA developed in, let's say, the health economy atmosphere is that it's directly going about prices of medications and the way you calculate, let's say, what is the quality of life of patients. And in this model, when you dive into it, there are a lot of aspects which does not reflect what is important for patients, for families with diseases, and that doesn't return back in the economic model in which HTA scientists are dealing with. For instance, when you have a family where, let's say, one of the parents is taking care for the child or the family member with a disease, and that means that this person cannot have an active career in society because they are caring for a family member, this is not calculated in the HTA calculation. And so there is much more. And it's very difficult to have a good dialogue between patient groups and HTA scientists about this, because what is natural in the physician-patient relationship is not natural in the HTA patient group or physician relationship, to talk with each other about what's really going on in daily life and how to express it in an economic model. That's the problem I experienced, and then it's also my experience for 8 years in an appraisal committee. Then when it comes up to a decision about high price for a rare disease, and when you ask HTA people or people in an appraisal committee, do you know people with this disease? They say no. Do you think it is important that we are talking with these people to get their opinions about what you are going to discuss. They also say no, because they say, well, we don't want to have that human factor into the discussion. And that's the problem in the dialogue.
Thank you. We have a policy of equity of access to the microphone, but we also have to, as in HTA and many other things, balance it with an attachment to excellence. So, Joe, you wanted to come in on that, so I'll let you come in briefly.
I totally agree with what Kees is saying. It was also the result of a large discussion when it was going on in Belgium with patients' organization that, for instance, the measurement, only economic measurement is not sufficient. You should include more aspects of quality of life. And I think, of course, when I say health technology assessment is not a hot potato, it's not a hot potato in question of trust. And of course, we should include these approaches and more criteria, multi-criteria evaluations, which should be put on the table. When I say it's not a hot potato, I think there is sufficient conviction and agreement that health technology assessment should be done. But it's my conviction that, of course, it should be modernized also, because we should have this evaluation also in real life, and then the patients are coming in, and that's health technology assessment 2.0. I think therefore there's a lot of work to do already. Sorry to add a little bit.
Not at all. Please don't apologize. That's what we're here for. Thank you very much for that. Philippe, when you were talking about your rare disease fund, and in fact I think it's a point that I've heard you make in more general terms as well, you spoke about the need for early dialogue, HTA and so on, but about the involvement of all stakeholders, and you put some emphasis on all stakeholders. Just tell me how far at the moment you feel all stakeholders are involved and which ones are not involved at the moment that you'd really like to see more involved.
I think if you look at it at a more general level, I think we have a lot of discussions in the European Parliament, in the European Commission, between Member States, European Commission, and there I think we try at least to bring the stakeholders around the table. So I think when you see the general dialogues, I think there everybody is represented, and also we try, for example, from the European Parliament to also host events and have actions towards patient organizations, for example. So I think we try to involve the different stakeholders, because we as policymakers also understand that we need to hear all sides of the story to come to conclusions to further some of the policies that we want to put in the field. But then, of course, we come into implementation and difficult decision-making sometimes, and I think what Kees was describing is exactly the case, that at that moment it becomes an economic, a technical, some would even say a bureaucratic decision-making process where some of the stakeholders are excluded, explicitly excluded. Others are excluded but find access through the back door. And I think this is something that we have to make much more explicit. And so I think that my point is that at European level and in the different member states, there is one big elephant in the room. That is that we have tried to put forward the universal healthcare as a model. But of course, in healthcare, it is always the case that demand is infinite and supply is not. So you always have to make decisions, tough decisions, difficult decisions. The only problem is today they are not made in a transparent way and they're not made in an objective way. And so I think that we have to find new structures, and Jo was talking about HTA 2.0, that's one element of the discussion, but I think that we really have to make some of the choices that we make more explicit and do it also on a much more evidence-based methodology. And I think what Jan was saying in his speech is also very clear, that when we only look at some general endpoints in clinical trials, then I think we miss part of the story. And I think that here, we as policymakers have to be much more explicit in the choices that we make, but also try to make the choices that we make much more objective and much more carried and being carried by much more stakeholders than today.
Okay, thank you very much for that, Philippe. Jan, I'd like to ask you, first of all, I know you want to talk about transparency and trust, and we'd like to hear that. But first of all, there was a lot of discussion of the risks of fragmentation, and you described the situation at the moment for many patients as a maze. The best way of dealing with fragmentation and a maze is to sort of try and remove the borders in the maze and get things working together. How much of a challenge is it then that at the same time many of the steps towards trying to find solutions in Europe are in fact local. You spoke yourself a little bit about this, smaller steps, as it were. You mentioned the Benelux exercise, as indeed did Joe. Is there a difficulty in reconciling this need for an overall approach for solving them, getting out of the maze, as it were, and the fact that many of the attempts at the moment are local rather than European?
One of the next steps probably is really for the national competent authorities pricing reimbursement of the 28 member states to give a green light and say, the one who are volunteering, get your acts together, we're supporting the process. It will be a learning curve, obviously. It will be stepwise, it will take time, but we need to start. I think we're faced with reality of cases of the last 2 years or upcoming, where we've seen that for rare diseases like Duchenne, when you address only a nonsense mutation, you're talking about a very rare population. And you're talking about the need to collect this data across Europe. We've seen that also with cystic fibrosis and treatment on different specific mutations. That doesn't work to pretend that each member state is going to ask for specific data collection or diverging things. We need to get the drugs fast to the patient, not only for the benefit of the patient and of their treatment, but also in order to collect the evidence to see what's the real value of that treatment, which patient should have it according to their profile, which dose, which regimen. And it's not a simple life. Usually it varies a lot. If we don't collect that, it will be the clinical practice that will continue to be bricolage between doctors and patients, even though you have these beautiful reports of EMA and HTA. And the other element, as I mentioned before, is industry. Is that industry recognizes these needs, that the driver is not only the economy, but is the science. So I think what we are lacking today, to answer your question, is that more direct dialogue between industry and payers to restore a mutual understanding and try to forge a new way forward, where we say, let's not address that only from the economic point of view to bring down the price as the only objective, but as Joe de Kock said very rightly, and Philippe de Backer, the objective is to link the science and the economic model, but to know more what we're talking about.
Okay, thanks. You wanted to talk about transparency and trust, I think.
Yeah, if I may, because transparency and trust was mentioned several times. I don't know how you will feel in this room, but based on a lot of discussions individually with you, our synthesis is the following, is that we know there is an issue of trust, and that the way to improve that situation would be to have more transparency. But when you've said that, that's the magic word, but we don't understand the same thing behind that. When we speak about transparency of price, some are speaking about knowing the real price, what is really paid by each national competent authorities across Europe, not talking about what's the construction of that price, when others will understand something else. And what we are saying as EURORDIS is to say there is something we need to stop, which is to pretend that transparency is based on value. And that's one of the objectives of that symposium, in the exercise this afternoon and tomorrow, is that it's not true. It's a misconception, and we need to collectively address that price is not based on value. If we all pretend that this is the model for industry and payers, we're going into a failure. It's one key element. And we are getting into more sophisticated definition of value, and that will be lengthily discussed this afternoon in breakouts with different proposals, and we're contributing to most of them, so we're happy that different parties are bringing that into it, ISPOR with some companies, but also academic people, common principles on value, a more sophisticated multi-criteria European transparent value framework to be piloted, so different elements. But tomorrow we will do simulations where we will be in the shoes of a CEO or in the shoes of a payer. And there is more than the value when someone decides about the price of a drug claimed by a CEO or a company. There is the other elements of what they have invested, what they want to invest next, and that may be good. What's the next product, the next indication, the next development? What's the reward for the investors? And here comes the financial analysts, which are promising big promises. And there is also the benchmark with the area, with the other product, what the market can bear. And this is the reason, one of the main reasons of the mistrust. This is what we need to address. We need to come to greater transparency on the reality of this economics of the companies with a good reward, but with more grounded into the reality of the economy of the company and of the development of drugs. If not, we're going to have growing difficulties. And the same for the payers, if I may conclude on that. What I understand from the payers is that the price count, what the budget impact is going to be, but they need to understand these elements more, because what they take also into account is more than value. They also take into account, do you have a plant of production in my country? Are you creating jobs? Do you have other products in your portfolio that we could negotiate in balance? So it varies from one country to another, but all these elements count. So it's not only about the value of the medicines, it's much more than that.
Okay, thank you for that. Now, I promised you would have a chance to ask your questions, and I'm going to give it to you. I know that the panel, many of the people on the panel also want to come back with other views, and I will, of course, give you a chance, each of you, to do so before we close this session. But we have 20 minutes or so, and I'm very happy to see if there's people in the room who want to ask questions, or Dennis is somewhere also, I think, who's telling me if there's people coming in from the outside. We'll start with one in the room. There's I think a lady who raised her hand there. Could we have a microphone over there, please? And perhaps you'd be kind enough to tell us who you are. I'm afraid I don't know everyone here, and where you're from. And keep your questions, how should we say, decorously concise, may I say.
Thank you. Stella Blackburn from Quintiles. First of all, my condolences to Philippe's mother. Her personal tragedy is also a European tragedy, that in a time when there's an authorised, effective drug, that there are still children dying. However, is it not time to change the paradigm that although compensation and payment for a drug is a member state competency, in the case of a rare disease, should we not try to have payment authorised by the European Commission, and that there is an agreed model, say something like cost of development plus 10%, and that this is automatic once a drug is shown to be effective?
Okay, thank you for that. I think we'll take also the question. Dennis, would you give us one of your questions from the outside world as well? Thank you for that, whoever sent it in.
Certainly. Just to let you know today, Peter, that we have actually 100 viewers on the online stream, so it's great, and there's a lot of activity on Twitter using that hashtag RareEU2016. So there was a lot of mention earlier of elephants in the room, so I'll throw you one from the online audience. And it comes from Nick Hunt, who's a trustee of a patient group in the UK, who wants to know about the actually potential consequences for the British rare disease community should the UK leave. Potentially a relevant question, obviously, given the reference situation that the reimbursement decisions in the UK have on other member states. And one just other question, if you don't mind, coming from a chromosome 11 group asking, do you think all EU pharmaceutical companies are ready to exchange information to develop the economic model, the economic driver, I'm presuming she's referring to there, that you spoke about earlier?
Okay, thank you very much for that, Dennis. Now, there's three great questions. We have 15, 20 minutes. If I give everyone on the panel 5 minutes to answer all those questions, we won't have lunch until 3 o'clock. So what I'm going to do is I'm going to ask each of the panelists to respond, if they will, briefly to the points that they would like to raise on any of those questions. And we'll go right along the panel. Andrea, can I start with you?
Sure. In terms of the willingness of the pharmaceutical companies, I cannot speak for all of them, of course. So I will speak for my company. Yes, we are. It's a necessity. What we did with the last product we developed, which is the first, by the way, the first stem cell-based product approved in Europe, that will have to be done because the development costs and the manufacturing costs are so weird in our history of the industry that we will have to have this discussion. So definitely it's important. It's important to also remember about risk and go back to the sustainability issue that I mentioned before. Who is bearing the risk? and sharing the risk appropriately, I think, is very important in this kind of access and reimbursement and price discussions. And this, unfortunately, brings on the R&D ecosystem in Europe. If no one is investing anymore in basic research, how can we develop new medicines in the future? And if companies are forced to invest themselves in basic research, how can we cope with the risk? I mean, a new basic research project has 0.05% probability of success, and it will cost more than €1 billion to develop a drug out of it with an 0.05% probability. Who is going to be in the game? VCs are not investing in that, and basic research is not their business. So risk is also a very important variable, I think.
Thank you very much for that. Philippe, your views on this?
On the first question, I think in principle, yes, but I think that we have to address a little bit further and deeper how this would work. I mean, in my proposal, it's very clear that also once you establish value-based and HTA discussions at European level, the pricing and reimbursement discussion can also take place at European level. But there are, of course, huge economic differences between the member states. So if you would negotiate the price of 100, it would be perfectly feasible for some countries in the European Union, but hugely expensive for others. And so I think also there should be a system behind that to make sure that also there you can still have the let's say, the buy-in into the European level, but at the same time prices and reimbursement can still be done at national level. So I think it's also part of the discussion between member states and establishing the trust that one is not paying for the other. But the big advantage, of course, is that the moment that you have a supply at European level, then you can also have discussions with reference centers and make sure that patients in every country do have access. And if a country doesn't provide access, that there are systems in place for neighboring countries to pick up these patients or to help to set up these kind of reference centers. So all these things, I think, should be part of a much broader and much more holistic discussion. Secondly, coming back to the previous point, of course there is also a reward. I think Jan always in these discussions also mentions this, that we have to also make sure that the industry can keep investing, can keep looking for new medicines on a basic scientific level through universities and research centers. But I see a lot of venture capitalists investing early stage, in a very early moment, even in drug development, trying to support some of these new innovations, especially also, for example, in rare diseases, where you see that now with the new framework, there is a lot of more activity going on. So by getting the policy incentives right, you can attract a lot of investment and speed things up. And I think that's also something that we should take into consideration. A small political statement. I'm not sure what will happen with Brexit, with rare disease organizations and the connection with the continent. So that uncertainty, I think, is another reason to vote in.
Okay, thank you. Joe.
I have no political statement, but I think all depends about on the Scottish people. But I think it's too political. No, but to be serious, European price. I think you should be aware, of course, that the idea of a European prize is not a new one, but the question is that reaching the social goals we will attend. Therefore, I think we need to more sophisticated model, taking into account differentiating of the not only the capacity of power, purchase power in countries, but also other elements. But I have a déjà vu experimentation in that sense that when we have discussed 10 years ago the cross-border directive, of course we have introduced principles about expertise center, and probably knowing that we are confronted with rare and orphan pathologies, not every member state will invest in these centers of expertise. Nevertheless, when I read, for instance, the cross-border directive, when there is no reimbursement in your own country, you will not send these people to these centers because they will not reimburse in their own country. Thus, Europe must be aware to not be confronted with its own contradictions by making policy. Of course, there is some of the people have questioned the impact of other policies. Of course, that's clear that the policy of some member states has impact on other member states. And there's also pleading in favor, of course, of a more common approach. But I think it's the idea of launching European prize. I think that had not a great chance in the discussions we have with our member states on senior level. They see that as a member state competence, and I think we have to convince and use all the arguments to say, okay, for some specific reasons, for public health reasons, for instance, you can breach some rules, and I think we should be aware of that a treaty is allowing that also.
Thank you. Kees.
Well, starting with the Brexit question, I yesterday saw an article from UK scientists making a strong plea that research is an international issue, is also an European issue. So those UK scientists make a strong plea to stay into the European Union. And I think that's also the success of rare disease communities in the past 10, 20 years. The internet made it possible to make strong advances and to have a strong European network of reference centers, etc., strong European patient organizations. So we have to deal with the situation that there is a strong anti-European current at the moment in European politics. But I think that as patient groups we have to stand up and say we are here for a strong Europe, and a strong Europe has to deal also with the administrative burden that has Philippe de Backer also mentioned. My guess is that about 60% of the price of drugs is due to the high cost of the administrative burden of clinical trials, registration, and reimbursement process. When we can lower that percentage of administrative burden, we can also lower the prices of drugs, and that's a European target we have to go for.
Okay. Jan, before I give the microphone to you, will you indulge me with a small fantasy? We're talking about Brexit. You gave a view of some of the scientific community. Can we have our referendum here for EURORDIS just right now? Would all those who would vote for Britain to leave the EU please raise your hands? Oh, I'm delighted someone is on the other side. Would anyone who would like to see the the UK vote to stay in the EU raise your hands? Oh, wow, that's a very narrow majority, but nonetheless pretty clear. Well, thank you very much. I think that's a nice little news piece we can put in somewhere. Thank you very much for that question, by the way. Jan, over to you.
Although you didn't mention if there was a package attached to staying in the EU.
I'm a journalist. I just go for the headlines.
I will follow up on what Keith just said, is that I know sometimes it's provocating by saying we should discuss about the cost, not only about therapeutic value. But who really understands outside of the industry how the costs are constructed? What's the cost of creating new knowledge, not only about the product, but about the disease often, to do natural history studies, to be the first to identify the endpoints, to be the first to build the network of experts. But also the technical challenges, as Keith said, of the clinical trials, when you have to travel patients from across different countries for these trials, and all the technical challenges you have, but also challenges of production often. And at the top of that, there is all the cost of regulatory. And maybe that could be a nice way to reduce some of the regulatory requirements, OHTA requirements, because then they will see how much it costs to ask them, and how much it costs to be fragmented in this requested. The last part of the answer, maybe to follow up on some of previous comments, is that I like to show more the opportunity of the new ecosystem that we have in front of us. As Joe DeCock said, it might not take, and Bill Gates, it might not take 1 year, and will take 10 years for sure, but it's the creation of the centers of expertise through member states, the creation of the European reference networks across Europe, and the registries at the core of that, or to put it more broadly, the system to collect data on the patients, on the clinical practices, through the clinical trials, post-clinical trials, research and protocols. So all this data environment is going to increase. We already have a lot of agreed interoperable patient files, e-prescription, so interoperability of registers, all that is coming up. And in these networks, there will be also the best practices of diagnostic and care, which will be defined. So there will be comparator with much more robust data than what we have today for everybody. So there is here a favorable ecosystem, and if tomorrow, ideally, some of these networks are able to provide quality data, then we will not need these product registries or whatever. We will be able then to produce the data that are needed by the companies. And so there is a real partnership that can take place around that. And even though it may not be immediate for tomorrow, it's because we make the right decisions and directions now that we may get it a few years from now.
Very good. Thank you for that. I think we have time for a very quick round of further questions. If the panel are happy about taking a few more and giving perhaps quick answers so that we don't get too far behind. There's a lady at the table there. You have a microphone down there. We can have another microphone there. And there was another hand up there at the back. Okay. Jesus Christ. Please, can you have a microphone down here to start with?
Hi, I'm Claudia Hirawat. I'm a volunteer for EURORDIS, but should disclose that I was the president of a publicly traded biotech company where I worked for 15 years. And my question is, in the context of elections in the US, the issue of prescription drugs comes up very often. And it eschews the discussion of the overall healthcare cost. Can you comment on what percentage of healthcare cost for the rare disease community the drug expense represents?
Okay, thank you very much. Now, there's another question over here. Where's the next microphone? We've got two mics. One of them was already over there, no? Yeah, with the white shirt.
Hi, I'm Gernot Sandu from Basel, Switzerland. I want to pick up the point that Case made about the psychosocial burden of diseases on patients and their families. The burden on the families is real. There's opportunity costs. Yet we pretend, and I would say as a summary, it's a tokenistic effort to try and incorporate that in. So my question to the panel, are we going to actually do this in a real way to look at the burden of the families in the equation, especially in HTA assessment with payers? Because it sounds like it's an open secret that no one's really interested to incorporate.
Okay, thank you for the comment. Was there other questions? Okay, and Dennis, any from outside?
Yeah, there's one very interesting question from, some of you may know, Alicia Granados, a renowned HTA thinker, who asks, why is no one questioning about what are the true contributors to health systems' lack of sustainability?
Okay, well, they're very splendid. 3 questions. And I'm going to ask the panel again, go right along the panel, and I'm going to ask the panel also, while they answer whichever of these questions they wish to offer any closing remarks, conclusions, takeaway messages that they would like to wrap up with. So you have about 2 minutes each for that, if my maths is roughly correct. And again, we'll start at that end. Andrea, please.
Thank you. Although I don't know the percentage of the expense for rare diseases, I know what's the pharmaceutical expense in Italy, and in the pharmacies. That means the general practitioners is about 11% of the total healthcare costs, and if we add a 2-point-something% in the special hospital care, the overall pharmaceutical expense is about 13-point-something, depends on the year, percent of the total healthcare expense in Italy. So I don't say it's much, it's not much, I don't know. I don't have a reference to say it's much or not, but I agree with the last question. So that's not the biggest spender in healthcare. Possibly there are others. I would like to make one remark about the data generation, because that's key. If we want to change the way we assess the value or the price of our products, We need to find the right time in which to collect the right data. May it be a randomized clinical trial, may it be real-world evidence. Real-world evidence is a beautiful idea, it's not there yet. We are, as a company, we are doing steps in that direction, but it's not there yet. It will be there, I'm sure, I'm positive about that. It will have a cost. It will be an investment cost at the beginning, and it will help reduce the costs afterwards. Unfortunately, that's the dynamic of investments. I agree that's to find the right balance and the right timeline, when to go from the clinical endpoint to the patient-reported or patient-centered outcome. That will be key to have a real effective access and pricing discussion, I think.
Thank you very much. Philippe?
We made with you a little bit back of the envelope discussion, drug expenditure 10-12%, and then 10% of that, so that's basically, but he has more advanced calculations because he has described a little bit further down. So that would be more or less the ballpark figure that I would mention. But I think your question also relates to the last question. And of course, we only get the 2 minutes, but of course, a lot of the discussions about the sustainability of healthcare systems as a whole, I mean, if drugs are only 10% of the expenditure, the true cost, then of course, we can still work on the other 90% also. And I think that in some member states, you see these discussions ongoing, or what's the cost of hospital care? Can we do some advancing there on making better collaborations? Can we share certain instruments, things like that? The bureaucracy in between. I mean, just to give you one example of my own country, people in Belgium who have a child with a rare disease, they have to register both at the federal level and at the Flemish level to get benefits, because it's split. And I think this is something that's totally crazy in a time where databases can be linked. I mean, why don't you do the single registration point? It saves you bureaucracy, but in the end it's also much more friendly for the parents and the patients. So these are simple solutions that, or at least I think there are simple solutions. In Belgium, nothing is simple. But I mean, the issue there is, of course, that these are things that we should take care of much more also with the patient in mind. And I think here, these are very concrete examples that I can give of the healthcare system in Belgium, but probably also in other member states, where efficiency will drive costs down in the end, but also will open up a much more friendly environment for patients to thrive and to do other things. Because in the end, it's about making choices, and I think that here, the 90% that we can still work on, and the true drivers of healthcare costs, aging, chronic disease, and things like that, are also, of course, elements that we can work, but the public discussion is often focused on the pricing of drugs. But I think that we as policymakers should really keep also the big picture in mind and try to keep working also on the other 90% to make it much more efficient than today.
Okay, thank you. Joe?
And let's look to prevention also, because that can also have an impact on the expenditure of health. According to the figures, I think that's not an important question. What I see, it's a moving target in that sense that, of course, the increase of new molecules is much faster, of course, than what we have seen in the past. And in a few years' time, for instance, the hospital pharmaceutical budget has doubled, and of course we should be aware of that. But as Philip said, okay, it's not as such the huge problem for the health system. The sustainability, of course, is linked by many factors, but I will globalize it. It's, in fact, if your health system is not a learning system, is not adaptive, you cannot, of course, guarantee the sustainability of that, and it's in fact a question of global performance of your system. You have to monitor both on the equity side, on the quality side, but also on the innovation side. A system which is not innovating anymore, of course, is not sustainable in the long term neither. And I think that's a global answer, but within the time we have, it's the only answer I can give for the moment.
Thank you very much. Kees?
Well, I hope you remarked it that when I used my slide on health insurance, I had a slide about a heart. And that was on purpose, because I think solidarity, humanity, That's why we have health insurance, to ensure unequal risks. And I think that at the moment we are trying to perform that, or to rearrange that into a kind of health insurance with equal risks for everyone. And that's more or less a problem at the moment. So I think we need to have more humanity in the healthcare system. And to get a sustainable healthcare system, I think we also have to look much more to prevention, because we are now treating a lot of chronic diseases, maybe some rare diseases, where also the impact of lifestyle diseases is, let's say, part of the comorbidity. And so I think prevention could be one of the ways where, let's say, every patient group has a responsibility together with other stakeholders to take care of the sustainability of the healthcare system. And with the solidarity, I also will answer the question in the back of the audience, that it's also a little bit my fear that, for instance, with a lot of changes in the labor situation of people at the moment in Europe, with a lot of flex work, that is a difficult situation for people with chronic and with rare diseases. And so we also have to take care in the labor force, in the social working environment for people to participate in society, that we can keep all the energy from people with chronic and rare diseases also into the labor force, because they have a lot of experience and they are very productive workers if they are able to work. So let's transform the medication also in the labor force and put it that way forward to come to a sustainable healthcare system.
Thank you. Jan, bring us to a perfect pinpoint landing at 12:30.
That I'm not sure, but before lunch. But I think we have a great opportunity during these 2 days. We have a lot of industry representatives, including top executives. We have patient advocates. We have policymakers or regulators and HTA. We have European Commission, MEPs. And the opportunity is that I think probably will agree that we don't want to continue to go off track as it is going. If we continue to see these diverging decisions as we observe increasingly, that I was mentioning before, we're not going to take advantage of the 30, 50 products per year to be approved. And an approved drug, if you don't have a market, you don't have your return on investment, and we don't have the drugs as patients. So for me, what we need to look at is the dynamic of things, we're looking too much at things at the time of the decision, of the market authorization, of the value assessment. But can we look more broadly at the life cycle of the product? Is there different time points? Is there a different process where everybody would feel more comfortable and with the proper process to feel good about the decisions they are making for each stakeholder? But also the dynamic of the politics around, as Joe mentioned. We need to look at, there is different elements going on at the moment which are going to crystallize. There is plasticity. That's the right moment. We know it from experience in so many other disease areas, cancer, AIDS, rare diseases. HTA, regulatory before. There is this moment where things are crystallizing. That's all we feel that's happening now in the next 2 years. So that's the moment to say it. And from our experience in working with most of you in this room, you have things to say. Please dare to say them. Feel good to share. We're in a safe place here to try to forge good ideas, good way forward that we can synthesize at the end of the day and take into these different initiatives around. That will be a great achievement for us.
Thank you very much, Jan. Well, that brings us to the lunch. It brings us to a break for our viewers from outside, but we will be back at 2:30, I think is correct, after lunch, when we will have the Commissioner with us, the Commissioner, 2 o'clock. 2 o'clock, sorry, 2 o'clock we're back. So before you dash off to lunch, I would ask you to thank the panel in the customary fashion, and thank you for your attention.
Ik zou graag een slide hebben met het